Good morning, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. It is my honor to introduce today's speakers who will be giving an insightful lecture on the role of radiofrequency ablation in papillary thyroid microcarcinoma. Dr. Juan Pablo Dueñas is an accomplished endocrine surgeon with a passion for advancing surgical care in the field of endocrinology. He holds a distinguished title in the Fellow of the European Board of Surgery, specializing in endocrine surgery. With extensive expertise in the area, Juan Pablo serves as Associate Professor of Surgery at the esteemed Universidad in Medellín, Colombia. He is an active member of various surgical organizations, including the Surgical Affairs Committee in the Latin American Thyroid Society, where he contributes his insights and knowledge to shape the future of thyroid surgery. Juan Pablo's dedication to his profession further is exemplified by the role of president in the chapter of endocrine surgery, metabolism, and nutrition within the Colombian Association of Surgery. And additionally, Juan Pablo was recently appointed as Secretary General of the Thyroid Nodule Therapy Association that recently held its last meeting in Reggio Emilia, Italy, where his contributions were crucial for the meeting and for the field. Before we begin the presentation, I want to encourage all of you to actively participate by using the Q&A function to send in your questions, and we'll try to address them during the Q&A session towards the end of the hour. Now, without further ado, I'm really happy to present my friend and esteemed colleague, Dr. Dueñas. The mic is all yours.
Good morning, Camilo. Good morning, Mark. Thank you very much for this invitation. This is a real honor for me to talk about the real tendency now of the change of the management of the thyroid nodule disease and even for microcarcinomas of the thyroid. Before I begin, I want to thank you for this invitation. It's a real honor for me to be here with all of you. I am Juan Pablo Dueñas, endocrine surgeon from Medellín, Colombia. I have not conflicts of interest of this conference. Well, between the possible indications for ablative thermal therapies includes patients with papillary thyroid cancer who do not wish to undergo surgery or who are not surgical candidates primarily due to associated comorbidities. Nowadays, a patient with microcarcinoma has 3 treatment options: surgery, mainly lobectomy, active surveillance, which requires a low-risk tumor, and management by a multidisciplinary team under a strict follow-up program. Finally, ablative therapies can play an important role in this group of patients. The ideal patient for active surveillance is one with low-risk microcarcinoma and no indication of immediate surgery. Patients that require immediate surgery are patients with presence of lymph node involvement or distant metastasis, with clinical apparent invasion of trachea or recurrent laryngeal nerve, with a diagnosis of aggressive histology in the biopsy, with a tumor attached to the trachea with possible invasion, tumor in the area of the recurrent laryngeal nerve like this, or invasion of the trachea like this, associated with another thyroid or parathyroid disease that requires surgery, or patients with age under 20 years. However, it is uncommon to see aggressive histology on fine needle aspiration cytology, yet they include it. And the age less than 20 years, it is because there is no evidence of this population of the results of these therapies. Also, it will be very costly to follow up patients at such a young age. And finally, there is not a strong evidence of localization of the tumor within the thyroid and its relationship with adjacent structures as surgical indication, but the recommendation today is that one. It's extremely important that the invasion of the thyroid capsule and metastasis of the lymph nodes should be carefully evaluated prior to evaluation by an thyroid ultrasound experts. Also, the indications for ablative thermal therapies in thyroid cancer are not clearly established. It is possible that patients who are contraindicated for surgery or patients who do not wish to enter an active surveillance program because of anxiety or because those prefer some kind of treatment rather than observation may include. The ideal patient with the ideal tumor will be one with a tumor away of postural medial zone of the thyroid, with at least 2 millimeters of healthy thyroid tissue around it and not in close contact with the trachea. Ablative therapies for treatment of thyroid cancer are not new. The first report of patient treated with microwaves was published in 2011, and the first trial with radiofrequency treatment for papillary microcarcinoma of the thyroid was published in 2016. The largest series reported that complete disappearance of the tumor posterior and ablation is almost 91%, with almost of them with a few complications after treatment. In another report of the systematic review and meta-analysis, it showed complete disappearance in 57% of the patients, with a recurrence rate very low, only 0.4%, and they conclude that thermal ablation could be an effective and safe alternative for papillary microcarcinomas of the thyroid when patients are not surgical candidates or are unwilling to undergo surgery. In this systematic review and meta-analysis with more 1,000 patients, the combined disappearance rate of the three techniques, radiofrequency, microwave, and laser, was 91%, with average follow-up of 20 months after procedure, with a very low recurrence rates, nearly 1% in other areas of the thyroid and 0% in the ablated areas. And the rate of minor complications was less than 1.8%, which is much lower than surgical complications. This group of 202 patients with 211 microcarcinomas, that means that some patient has at least 2 tumors, underwent radiofrequency ablation and biopsy of the ablate central and peripheral area at 3 and 6 months of follow-up. And 99% volume reduction was achieved at 24 months of follow-up, and 3 patients had positive biopsies and underwent a second ablation. No lymph node metastases were observed during the follow-up of the procedure. This is the evolution of this kind of patients, and 80 months after radiofrequency ablation, the tumor is completely gone. So the question is, can radiofrequency replace surgery? From a cohort of patients under surveillance after radiofrequency for primary low-risk papillary thyroid microcarcinoma, those with a record of follow-up for more than 5 years were included in this study. A total of 84 nodules from 74 patients were included, and the mean follow-up duration was 72 months. After radiofrequency, complete disappearance rate was 99% at 24 months and 100% at 60 months of follow-up. During the follow-up period, there was no local tumor progression, no lymph node or distant metastasis, and no patients underwent delayed surgery, with a very low rate of complications, minor complications, that was only 1.4%. This is the progression, similar like showed before, of this kind of patients with a completely gone tumors at 3 years after radiofrequency tumor. For tumors smaller than 5 millimeters, complete disappearance was achieved at 2 years of the follow-up. For tumors between 5 to 10 millimeters, disappearance was achieved at 5 years of follow-up. In this study, 440 patients was treated with radiofrequency. Our main follow-up time of the follow-up time range from 24 to 69 months, with a mean reduction volume of almost 99%. After radiofrequency treatment, 88% completely disappeared during the follow-up, and the overall incidence of local tumor progression was only 3.6%. Among them, 1 patient was diagnosed with half a residual cancer and underwent another radiofrequency treatment. 4 patients developed metastatic lymph node, and 10 patients had a recurrent papillary microcarcinoma during the follow-up, and 13 of them had a new radiofrequency treatment with disappeared in 11 of them. In this study, 91 patients in each group with tumors between 1 to 2 centimeters underwent radiofrequency versus surgery, and their outcomes were compared. The rates of local or local tumor progression and complications were similar in both groups, but the procedure time and the cost was much lower in patients with radiofrequency. In this other study, 174 patients with isolated solitary intrathyroid microcarcinomas were identified, 94 patients under radiofrequency treatment, and 80% on with surgery. Of them, 72 patients under lobectomy, 27 patients for total thyroidectomy, and 66 patients underwent lymph node dissection. The complications has present only in the surgery group, with 2 permanent recurrent laryngeal nerve lesions and with case of permanent hypoparathyroidism, and no complication was present in the group of the radiofrequency. The rate of local tumor progression was similar in both groups, as you can see, as was the incidence of new tumors and lymph node metastasis, with not a statistically significant difference. This means that radiofrequency ablation therapy is as effective as surgery in terms of oncologic results. Finally, the patients with papillary microcarcinoma under radiofrequency has a better quality of life compared to surgery, that which supports that the role of radiofrequency is a very good alternative to surgery for this kind of patients. This patient, this is a female patient with a thyroid nodule in the left side of the thyroid, 12 millimeters, TRAS5 is a hypoechoic irregular nodule with I think microcalcifications, and the biopsy shows a Bethesda 6 for papillary microcarcinoma. This patient wants choose radiofrequency ablation as primary treatment, and this is the image on the ultrasound at 3 months, 5 months, and 9 months post radiofrequency treatment. At that time, the patient decide going to surgery because she doesn't have that shadow in the inside of the thyroid, and the final pathology of the lobectomy only shows fibrosis without evidence of tumor cells. This is another patient with a 36 years old female with an incidental thyroid nodule on a PET scan because she had adenocarcinoma in situ on the cervix. This is the image of the PET CT, and this is the image on the ultrasound that shows only a TRAS5 lesion of 8 millimeters, and the biopsy a Bethesda 6 for microcarcinoma, for papillary thyroid carcinoma. The patient has not desired for surgery of active surveillance. This is the image of the radiofrequency ablation date. It was in November of 2002. This is the image of the nodule after hydrodissection, and this is the image of the thyroid lobe, and this is the site of the nodule, and it is immediately after radiofrequency. At the 1 month follow-up, we only see a hypoechoic area of 7 millimeters, but the most important part, this is a new area without vascularization. As you can see, there is no vascularization inside or in the peripheral zone of the nodule. At 4 months, we have now a nearly isoechoic area in the ablation zone, and this is the image 3 years before, with a follow-up at 9 months. I ask for my patients always between 6 to 9 months after ablation, a new biopsy of the central or peripheral zone, and there is no evidence in this patient malignant cells. And as you can see, this is the image inside of the thyroid, only we see a little very small area, hypoechoic area. So this is the evolution of this patient. This is the primary tumor 9 months ago, and this is now with no evidence of tumor right now. So at the end of the day, we have 3 minimalistic management options for patients with microcarcinoma: active surveillance, thermal ablation, and thyroid lobectomy. This table summarizes 40 published case series evaluating the efficacy and safety of the thermal ablation for papillary microcarcinoma of the thyroid, which more than 5,000 patients and nodules treated, most of them with radiofrequency, even with multiple lesions in this, with multiple tumors in the same session. The development of dysphonia is very low, only 1.4%, and all of them recovery at no more 6 months. Recurrence in the treated area was only 1.2%, and lymph node metastasis identified during the follow-up was only 0.6%. In summary, the ablation, the thermal ablation in primary microcarcinoma of the thyroid has a great potential in the near future, with a low rate of complications, do not affect recurrence and rate compared to surgery today. Is a very good alternative for active surveillance when the patient has not decided and the patient has to know the risks and benefits. It's very important that we need more evidence with large areas with a long-term follow-up in comparison with surgery, because we need more information to make a strong recommendation. So at the end, this is very important that we need an ideal patient when an ideal tumor, but more of that, we need an ideal patient, one ideal tumor, an ideal team of management. For me, the ideal tumor is it is a well-defined microcarcinoma, micropapillary thyroid carcinoma with 2 millimeters of normal thyroid parenchyma surrounding the nodule, with no evidence of multifocality or cervical lymph node metastasis. The patient in the middle of this in this management strategy has to motivate it to avoid surgery and willing to accept active surveillance and embrace novel therapeutic management options. And the team has to be multidisciplinary management team with that extensive experience with the specific ultrasound guide percutaneous ablation technique that we'll use. Maybe we are now in the most important change in the management of the thyroid nodal disease, even benign diseases and even malignant disease. And at the end of the day, and at the end of this year, maybe less is more. Thank you very much.
Juan Pablo, thank you so much for this very interesting lecture. I have a couple of questions, and I would like to give Dr. Erkin, if he has any questions, the opportunity to ask you, and then I have so many things to ask you to drive an interesting discussion. Dr. Erkin, do you have any comments, questions?
Yeah. So why don't you start, Camilo, and then we can go back and forth here with questions here. But Juan Pablo,
Perfect.
thank you for a wonderful presentation, and it opens up so many discussion points that I'm sure clinicians are wondering about here.
Of course. So in one of our past lectures, and I'm sure that many of the people here in the audience have heard Dr. Ashok Shah say that first the surgeon has to learn how to operate, then when to operate, but the best surgeon knows when not to operate. So you spoke about the ideal patient for undergoing radiofrequency ablation in papillary thyroid microcarcinoma. But could you please hone in on when not to do it? When, like with every new technology, with everything that's new in medicine, we often have a learning curve and we start using it, and then there's like a snowball effect and everybody wants to use it. but there's a risk to that. So can you tell, like, for the less experienced users or the less versed people in radiofrequency ablation, could you say when not to do radiofrequency ablation?
Well, in terms of malignant disease, this is very difficult because we don't have a strong evidence of the results, but we have to be very careful in the selection of the patients. The first thing, as when the patient desires surgery or desires more treatment, we have not to pressure them to make an ablation because it will be very risky in the future. Nowadays, I perform ablation for microcarcinomas in only 9 patients. This is a very good number, I think, but that patients ask for me for ablation. And after that, I perform a very careful evaluation of the neck with ultrasound. This is the most important part. More than the durability to perform the ablation, the mainly is the evaluation of the complete neck, all levels, look for lymph node metastasis on lymph node or nodes, suspicious lymph nodes, because with patients, we know that the probability of cervical lymph node metastasis in the central compartment are very high, but most of them maybe that doesn't have clinical significance. But we need to perform a very good ultrasound evaluation to discard lymph node metastasis. And second, the tumor inside of the thyroid has to be the low-risk ultrasound features. How? I perform only ablation for tumors very in the central area of the thyroid for now, because I don't want risk for patients. I don't want burn the trachea. I don't want burn the recurrent laryngeal nerve, and we don't have enough evidence and information, a long-term follow-up. So we have to be very careful to do that. And not all patients are candidates for radiofrequency ablation, as not all patients are candidates for active surveillance. So the ideal patient for this kind of treatments are the ideal patient for active surveillance, I think.
Camilo, there's a question from the audience regarding extending the indications to get up to 1.5 centimeters, whether you would consider that, kind of how large do you foresee treating I assume a biopsy proven, but the question comes as to whether or not for indeterminate nodules that are either Bethesda 3, 4, or 5 cytology, would you consider using RFA in that setting? First the size, and then the issue of indeterminate.
Well, active surveillance at the beginning was for only patients with tumors until 10 millimeters. And after the evolution of time, extend to bigger nodules until 50 millimeters. I think it is not a very good recommendation today because we need more evidence of the results of the procedure. I think it will be the first option of management for micropapillary thyroid carcinomas in the near future. But we have to be very careful with that because it could be very risky, I think, because we don't know what the future will have in that patient. So for the size, for now, nowadays, for me, only for tumors until 10 millimeters. And for indeterminate nodules, there is, for me, there is no option for treatment because some of them could have follicular thyroid of the could be follicular carcinomas of the thyroid, and maybe with the introduction of the molecular testing, it will be, and if the molecular testing is negative, it could be an option. But for now, this is not the first line of management, and I don't recommend it.
Thanks.
So I have a
Thank you.
Yeah,
Yeah, go ahead.
question. Yeah, Juan Pablo. So are you, I guess the question becomes, there's this push-pull here between identifying a nodule that has high-risk features. Are you biopsying these before you recommend RFA, or are you doing this just based on ultrasound features that suggest that it's a high-risk high-risk nodule? What is your current practice?
Well, the guidelines doesn't recommend a biopsy for nodules less than one centimeter, but in order to have a good diagnosis, I always, if I have a high-risk nodule on ultrasound features, I perform a biopsy to know which nodule is and which is really his malignancy risk. And yes, I perform if the nodule has high-risk features on ultrasound, I perform biopsy.
Awesome. I have another question. The question about intermediate or indeterminate nodules is a good one, and I feel, and you're the expert, and you can correct me if I'm wrong, but it is a similar story of what happened with active surveillance way back in the day. The difference between the active surveillance story and the radiofrequency ablation story is radiofrequency has been more it has a bigger use in the past couple of years, and we have a pandemic that hit us right in between. So the learning curve has been slower. The evidence and the publications have been less than what active surveillance is. So we're kind of splitting hairs the same way we were with active surveillance maybe a decade ago and ever since. So the next question is going to be yes,
that
go ahead.
Yeah, I think that the history of management of the thyroid nodule has changed after introduce of radiofrequency. And you're right, since 2 years ago or 3 years ago, it will be a pandemic of the use of radiofrequency with a lot of interest on the results and how to do it. And it could be dangerous because everybody wants to perform radiofrequency now. And this is very important that we need a very good skills on ultrasound. We need skills on biopsies, and we need a very good training on radiofrequency ablation therapies to perform the ablation. This is not difficult to get, but we have to do it in the correct way right now. This is one part of the TNT Association. This is very important for us because we want to write and to write the recommendations and the standardization of the technique, the standardization of who could perform a radiofrequency with which a minimum of skills to perform, because it could be dangerous. New technologies becomes with new complications, new procedures, new complications. And we have to be very careful because we need that the radiofrequency ablation, we need that kind of therapies, I think, will be the first line of management on the next future of multiple thyroid nodule diseases. But we have to be careful to select and careful to how to perform the procedure, because we don't need and we don't want new complications in our patients.
Yes, and that takes me to the next question. Dr. Ibrahim Saif, he asked a question after radiofrequency ablation, what do we do? So I wanted to ask you, what is your general protocol of how to manage a patient before and after radiofrequency ablation? So the question is going to be this. You were speaking before about the patient with aggressive histology and with capsule involvement is not a good patient for RFA. So when you say aggressive histology, most normally we get a patient that has a Bethesda, when we're speaking about microcarcinomas, Bethesda 6 result. But Bethesda 6 includes different types of tumors. That includes medullary, that includes, I don't know, even metastatic tumors to the thyroid gland, other things. So how do you, what is aggressive, what is not aggressive? That's one question. And then after you do RFA, what is your follow-up? How often do you do an ultrasound? And as some societies propose, do you do biopsy after the fact, after the radiofrequency ablation?
Yeah. For the first question, many groups, mainly in China and Korea, perform a core needle biopsy for in the tumors, and most of them says that they can identify the subtype of papillary thyroid carcinoma. For us, it is very difficult because I don't perform core needle biopsy, only fine needle biopsy, and it is impossible to get the subtype of papillary thyroid carcinoma with that kind of biopsies. So this is a point that I said to you in the third slide, that this is very difficult to get. So we only have papillary or not papillary, and as the aggressive histology is very difficult to get with a fine needle biopsy. And the protocol includes a very good hydrodissection. This is the most important part for the safety of the ablation, even for benign nodules than malignant nodules. Maybe more important for malignant nodules because the rate of complications in terms of this transit dysphonia or permanent dysphonia after procedures is higher in that group of patients with malignant disease. The paper shows that patients with ablations for microcarcinomas or ablation of recurrent recurrent tumors in the central net has more probability of recurrent laryngeal nerve lesions. The importance of this is the majority of the lesions of the recurrent laryngeal nerve are transient, and all of the recovery in the next 6 months. So I perform always a laryngeal examination in order to look for the movement of the vocal folds. It's a very good way to evaluate the probable invasion of the recurrent laryngeal nerve. I perform a very good hydrodissection of the thyroid in order to avoid thermal lesions in the surrounding structures. And the first evaluation, I performed my first follow-up at 1 month after radiofrequency, 3 months, 6 months, and 1 year. At 6 months of the ablation, I always do a new biopsy of the central area and the peripheral area of the ablation zone in order to look for malignant cells. Any patients of my patients has had recurrent lesions or new lesions. So I need a very good protocol because all of these are investigation. This is not a first line of management, and all patients treated for microcarcinoma, micropapillary thyroid carcinoma has to be in a trial of investigation.
Juan Pablo, just to follow up of that, I know these are small lesions and the data published says no hypothyroidism results of doing such small radiofrequency ablation, but do you at any point in time do TSH evaluation to evaluate for the function of the thyroid gland?
Yes, always, always. Well, I perform more than 150 ablation for benign thyroid nodule diseases, and any patient of them has in hypothyroidism. And this is the most important part of the new treatments with thermal ablations, because we really preserve the thyroid function with this kind of treatment. It is amazing. In benign nodules, the reduction rate of the volume after 1 year of treatment is almost more than 80%. Or this is amazing, and it is the same for benign nodules, for malignant nodules, so that the reduction is amazing at point that the lesion disappear of the thyroid nodule. You can see it. It is amazing. So it will be the first line of management. I think we need evidence for that. We need a work on it in very responsible way, and we have to be very careful. I repeat, sorry, but I have to repeat that. We have to be very careful in the selection of the patients, of the good patient with a good tumor, with a good management team, to offer a very good result to our patients.
Awesome. With that in mind, the volume reduction thoughts, I want you to hold that for a second. Dr. Mike Villa from Mount Sinai, he says, it is impressive to see lesions completely disappear over time without residual scar. In the pathologic samples, especially in the ones showing fibrosis replacing the lesion, were there any gradual histologic changes noted in the normal thyroid tissue surrounding the ablated lesion, or was there an abrupt change right at the site of the lesion? And secondly, what markers during the procedure help determine that sufficient energy is delivered to the lesion?
Okay, well, for the first one.
The first one, so is there a change surrounding the ablated region?
Yeah. The thermal ablations produce a very good area, depends of the active tip of the electrode, but the thermal ablation zone after activate the electrode is almost 1 to 1.5 centimeters. So if you put your electrode in the middle of the tumor and activate until the impedance grows more than 300, it means that that zone are completely burned. So with only one shoot of the electrode, it is enough to achieve a very good ablation of tumors less than 1 centimeters.
Right.
The second question is,
what markers during the procedure help you determine sufficient energy has been delivered to the lesion?
The marker of electrical variables during the ablation are the watts, impedance, and energy. The most important is the impedance, because impedance means the capacity of this disseminate the energy. When we have a peak of impedance during the ablation, it means that zone are enough heat, we have enough heat and enough burn, and this is enough to stop the ablation. So the most important marker during the ablation is the impedance peak.
Of course. So for listeners that have not been exposed to a radiofrequency ablation in the past, I would just want to ask you a couple of things. So impedance is the capacity of the tissue to conduct energy. So once you burn the tissue, it loses that capacity to conduct that energy. So the impedance starts rising quickly. And during the procedure, somebody will be assisting you, telling you what the impedance is. So when it hits a level, you will say stop, and you will stop.
Yeah.
And go ahead.
No. And yes, and now I use StarMed radiofrequency equipment, and they have a little screen that I put in the lateral zone of my sonograph, my echograph, and it shows the peaks of impedance at the number of the impedance, and one person beside of me always say, okay, the impedance right now is 70, 70, 70, 70, 100, 200 peak. And in this point, I move in benign nodules, I move the electrode throw back. But for microcarcinomas, when he said to me that I have the peak of impedance, I stop here until the maximum peak of impedance, because in radiofrequency for thyroid, microcarcinomas is different for benign nodules. In benign nodules, I don't want to have a peak of impedance.
Exactly. So again, for the people that have not done or seen a radiofrequency ablation techniques, normally in a benign thyroid nodule, when you have a big nodule, you would do what is called the moving shot technique, which is moving your needle in a fan-like fashion to burn the entire nodule. When you're speaking about microcarcinomas, when you have a much smaller target, do you also move your needle across the nodule, or do you just put it in and sit in a place and start the energy so it burns the lesion, more like what they do in the liver than what we do in the thyroid? What is your procedure?
For microcarcinoma, we don't use,
yes.
I don't use a moving shoot technique, because Perfect. It's a very small area, and with only one activation, maybe it is enough to get a very good area of treatment. So it's different for benign lesions, because benign lesions are bigger, much bigger than microcarcinomas. And in this case, in that cases, I always use moving shoot technique for the posterior zone to the anterior zone, in order to get a treatment of more than 90% of the surface of the nodule.
Oh, awesome. We have another question coming from the audience. It says, do you think there's a role for cytogenic, meaning molecular testing, Afirma, ThyroSeq before ablation? So for patients who have, I'm guessing, indeterminate nodules, would you consider doing ThyroSeq or Afirma or any of these tests before ablation to choose your patient appropriately?
I think that it will be a very good option for indeterminate nodules. For us in Colombia and in Latin America, very difficult get access to the molecular testing due to the cost. The cost for us is very high. I think that the cost of the molecular testing is the same that the cost of the radiofrequency treatment, is the same that the cost of the surgery. So it is very difficult. But if we want to perform ablations in the future for that kind of nodules, I think that molecular testing has to be mandatory to perform it.
I think, Camilo, I think the follow-on question to that is the role of molecular testing for confirmed malignancies to find out if there are high-risk mutations and how that would influence the decision for management here. So would a BRAF mutation, would a BRAF plus TERT mutation affect your decision-making for what would otherwise be perceived as a favorable low-risk micropapillary, what you would see ultrasonographically as a low-risk micropapillary thyroid carcinoma?
For me, I sure.
So the question would be, Juan Pablo, if you have a PTMC, a sub-centimeter nodule, but it has BRAF or BRAF plus TERT mutations, for example, would you still do an RFA? Is that an appropriate thing?
No. Patient with high-risk mutation has to be under surgery.
But if you're not doing molecular testing on all patients,
No.
How do you know what you're dealing with here, right?
Tricky.
Yeah. It is very difficult. So we have to trust in our ultrasound skills and in our ultrasound machine. Depends of your machine, you can see a very good image of the microcarcinoma. So the microcarcinoma has high risk image and low risk image of microcarcinoma. If I have a very surround microcarcinoma without speculations, without not too close to the capsule of the thyroid, not close to the trachea, maybe it could be a low risk microcarcinoma. It is very difficult, but for active surveillance is the same, because I don't know, but I think that the patients with under active surveillance doesn't have a molecular testing in all patients, and it is the same. I think I agree with you that the best way to offer a management is with a molecular testing, but it is very difficult in the world to offer that kind of management due to the cost and due to the access to the molecular testing around the world.
Milo, Dr. Chen brings up an interesting question, but it also addresses one of the contraindications that you brought up, Juan Pablo, and that is for multifocal disease. And Dr. Chen, who's a cytopathologist at Mount Sinai, raises the question of the patient who has undergone a hemithyroidectomy and now presents with a biopsy-proven second focus of disease in the contralateral lobe. So maybe if you could just address the question, why not use RFA for multifocal micropapillary, and how would you manage this particular case of a patient who presents after they've undergone a partial thyroidectomy with a new lesion in the opposite lobe?
Well, as you can see in the papers, and many patients had more than one tumor, and they were under radiofrequency therapies. For this case of patient with a lobectomy for microcarcinoma and has a new lesion in the residual lobe, for me is a very good patient for radiofrequency treatment, because for sure I avoid an hypoparathyroidism in that patient, for sure. There is no way to the patient has in the future hypoparathyroidism, that because for me this is the worst complication for after surgery. The hypoparathyroidism is very bad for the patient, and the quality of life of the patients with hypoparathyroidism is very bad. So for that patient, for me, this is a very good option. I think that patients with multiple tumors, depends of the localization of the tumor inside of the thyroid, could be a very good option, a radiofrequency treatment, more than surgery and more than total thyroidectomy for patients in that case.
Milo, if I could just ask another question here. You present this as three options for the patient who presents with a micropapillary. One is active surveillance, the other is conventional surgery, and the third is RFA. Obviously, there are certain exclusion criteria that do not make a patient a good candidate for active surveillance, and in most of those are the same exclusionary criteria for RFA. But for the favorable patient, why do we have to think about this in a binary fashion? Meaning, why do we have to make that decision that we're going to do something? And why not convince the patient that it makes sense to perform active surveillance for a period of time to determine the biology of that tumor before we commit to RFA I understand there are psychological issues here that may preclude that, but certainly there's no rush to intervene. We know that. And why not determine the biology and say, look, if this nodule remains stable in 3 months, we may be able to save you from having the expense or any intervention. And we'll see you again in 6 months, and then maybe 6 months after that, and delay the decision. Essentially taking the path of active surveillance, but if there is a change, notwithstanding the presence of new lymph nodes, but if there is a change, then intervene with RFA.
Yeah. Active surveillance is a very good option for patients. In fact, my patients under radiofrequency ablation was patient under was the perfect patient for active surveillance, and the endocrinologist under in the management of that patients start with radiofrequency with active surveillance of them, but all of them during the follow-up ask to the endocrinology for a definitive management of your nodule. I agree with you. With microcarcinoma, we can start always, depends of the risk on the ultrasound. We always can start with active surveillance, and because most of that tumors has a benign evolution during the follow-up, so it's a very good option. Always start with active surveillance. So the patient candidate for radiofrequency is the patient that is candidate for active surveillance, but some reasons, anxiety, desire more treatment, or I don't know, desire more for another option for treatment. If the patient has not very good candidate for active surveillance, this patient is a candidate for surgery. If the patient is not a very good candidate for active surveillance, has to be under surgery. I agree with you. We can start always with active surveillance and see how it is the evolution at the biology of that tumor during the follow-up.
I have an interesting question for you that just came to mind here. So why do you commit to doing a biopsy before you do RFA? If you have a high risk 10 millimeter nodule, do you commit to doing a biopsy? I asked this before, but I just want to clarify this.
Yes, I perform biopsy, multiple biopsies of the nodule in the central and in the peripheral disease. If we want to offer some treatment to the patient, we have to know what kind of tumor has the patient, or what kind of the Bethesda has of had the patient. Always perform biopsy, even because if I want to offer a treatment to the patient has to know what it is your diagnosis before the treatment. Even the treatment will be active surveillance, of the treatment will be a radiofrequency ablation or surgery. And in our group, the endocrinologists always perform biopsy in nodules even less than 1 centimeter with high risk features.
So let me take you one step further. You have a patient with a 9 millimeter nodule. It's Bethesda 5, and they have a BRAF mutation. So we think there's a reasonably high chance, a very high chance, that they've got a cancer. You decide to do RFA, and the lesion disappears. What is the patient's diagnosis? Because
this is a very good question.
Well, not really, because
this is part of the evolution of this technique, and this is part of what we need to know in the near future that which is the correct way to manage.
So
Sorry?
it does have, yes, I agree with you. But if one thinks about this
Hello?
from the patient's perspective,
Yeah.
they may never have a diagnosis of cancer, which can be a good thing on many levels, right? So, yeah.
Yeah, it is the same for active surveillance.
Sure.
So it is the same. It's a gray zone that we have to clarify in the future.
Great. Very,
Juan Pablo,
yeah, very thoughtful.
I have another question. You were saying before that we have to rely a lot on our ultrasound skills and what we do for what we do in a radiofrequency ablation, being a PTMC or a benign nodule. And I wanted to ask you two questions. When you were showing your slides, you showed a case where we could not see any vascularity inside the nodule after the fact that you had done radiofrequency ablation, and you saw that using Doppler ultrasound technique. However, there's some people specifically in Spain, Dr. Javier Serres, he uses contrast enhanced ultrasound. Do you do that? Is that something we should do? Do you find any value in doing so?
Well, for us and for me, it's very difficult to have contrast enhanced ultrasound because the disponibility of that technology, we don't have it in Colombia now. And after that, if it's very expensive technology. I think that in tumors, small tumors, Doppler evaluation is more than enough to get a very good information about the vascular viability of the tumor and the vascular residual after procedure, because there are very small lesions and the possibility of residual vascularity is too low.
Beautiful. And one last question, and I think this is not commented enough in the meetings and in the platforms where we speak about radiofrequency ablation. But currently the ATA and the thyroid ACR, they have guidelines, they have recommendations about how to perform and do an ultrasound. However, the question about volume is not highlighted enough. And when we speak about the radiofrequency ablation, the volume reduction is a key measurement or a key marker of how you're doing after the fact. And when we see ultrasound reports, we often don't see a volume report with that to the nodule to see how we're doing prospectively after we've done radiofrequency ablation or before. What do you have to say about that?
Yes, o sea, for volume calculation, we need 3 dimensions.
Yes.
The 3 dimensions of the nodule in centimeters, plus 0.543. This is the formula to calculate the volume of the nodule. Many reports from radiologists doesn't made that's 3 measures of the volume of the nodule. So in my patients, I always see my patients and I always perform the ultrasound in my office in order to get the 3 dimensions of the nodule and get a very good information about the volume and the volume reduction for calculate a very good way. Because many radiologists don't report 3 dimensions of the nodule. So we have to do it in person and in our own way.
Great. There's one question that we left pending from the audience, and I'm just wanting to ask you just really quickly before we adjourn. It says, do you believe that there is future also to include larger tumors or metastatic lymph nodes using RFA?
Okay. For larger tumors, the first option will be surgery. We know DOP, and this, I think that the only in the future, the surgery only will be for big tumors. Big is how much? I don't know. Maybe tumors more than 50 millimeters or 2 centimeters. I don't know, the time we have the answer for that questions. But for bigger tumors, surgery is the first line of management. But for recurrences of tumors in the lymph nodes, less than three recurrences to lymph nodes, less than 2 centimeters, radiofrequency is a very good option to manage that kind of situations.
Okay. Thank you so much for your answers, for your time, and for your very, very interesting presentation. I want to thank all the audience for being here and for taking the time to share with us this morning. And we hope to see everybody back next week. We will have our tumor board with cases presented by Dr. Fernanda Weissman from Gavea Central in Medical Center in Brazil. So thank you all. Have a great weekend. And Juan Pablo, thank you very much.
Thank you very much for this invitation. It was amazing. Thank you very much.
Thanks, Juan Pablo. Thanks, Camilo.
Hey, Mark. Thanks,
Bye-bye.
Mark.
You bet.
Thanks, Camilo.